Welcome. Good afternoon, everyone. My name is Alicia Rice, and I'm the program manager on the training and education team here at the MaineHealth Center for Tobacco Independence. I'd like to welcome you to our ongoing webinar series. This is one component of our tobacco treatment and prevention education and training program. It's sponsored by and brought to you on behalf of the Maine Center for Disease Control and Prevention, Department of Health and Human Services. This webinar will be recorded and posted to our website following the presentation today. Of note, we are offering 1.5 continuing medical education credits and 1.5 CHES credits for this webinar. This will be sent to those who attend the entire session. In order to claim CMEs, you must have a profile in Cloud CME. If you already do, you will find your credits in your profile within a week of the event. If you do not have a profile in Cloud CME, you can find the instructions on how to make a profile in the post-webinar email. And for those of you that are collecting CHES credit, record of your attendance will be sent to NCheck after the webinar today. Only those who registered for the webinar, connected via the Zoom link, and attended the full session will be able to receive CMEs and CEUs, as we are required to verify those who attend. And then at the conclusion of today's webinar, an evaluation will appear on your screen as well as be sent to you via email within 24 hours after the event. We do encourage you to take the time to provide your feedback. It's not only helpful for us planning our webinar series, but also to our presenter as well. So today's webinar is titled Co-occurring Cannabis and Tobacco Use, Understanding the Link and Treatment Approaches, and is presented by Edward Perka of MaineHealth. One more note before we begin, just a couple of housekeeping items. This is a webinar, so attendees will remain on mute to minimize the background noise. The raise hand feature is disabled for this type of event. If you're looking for a more interactive session with opportunities to engage directly with presenters, we recommend attending one of our standard trainings. But I do welcome you. Please feel free to submit any questions that you have during the presentation using the Q&A box. We will address them as time permits throughout the webinar. We may not be able to answer every question live, but rest assured that all unanswered questions will be collected and responded to in a post-event email. And for your convenience, a copy of this presentation will be sent out via email after the webinar. With that said, at this point, I'd like to turn it over to Edward.
All right. Thanks, Alicia. So thank you, everybody. Thank you so much for joining us today for this discussion about the co-use of tobacco and cannabis. As Alicia said, my name is Ed Perka, and I'm an educator on the training and education team here at the Center for Tobacco Independence. I've been an addictions therapist for over 30 years, primarily in New York State as a credentialed alcoholism and substance abuse counselor, or CASAC, as we know it in New York. I'm also a tobacco treatment specialist, and I've been providing education and training on tobacco treatment to healthcare providers, behavioral health providers, and educational institutions for the past 18 years. So let me set the stage a little bit. So at CTI, our focus and our expertise is the treatment of tobacco use disorder, or TUD. At the same time, I think we all understand that we can't talk about TUD as if it's in a silo all by itself. So people with TUD often have other co-occurring disorders as well, whether it's a physical health concern or a mental health disorder or another substance use disorder, or even all of those at the same time. In fact, we know that the prevalence of tobacco and other nicotine use is much higher in people with mental health disorders and other substance use disorders, and that this population actually bears a disproportionate burden with respect to tobacco-related disease. So, as providers of tobacco use disorder treatment, I think it's important that we understand some of the linkages and some of the connections between TUD and other physical and behavioral health concerns, and hence the reason and the rationale for this webinar. So we chose this discussion of the linkages with cannabis as a good starting point. In fact, in the majority of our trainings, questions about cannabis are posed all the time. So it's become apparent that this is an issue that many of us find challenging and could use some additional information and guidance about. So feel free to share any comments or questions or observations or concerns that you may have during the presentation, again, using that Q&A feature, as that always contributes to a rich and useful discussion, right? So let's jump in. So let me share a little bit about CTI first. So the MaineHealth Center for Tobacco Independence, or CTI as we call it, has served as the primary contractor of the Maine statewide tobacco treatment initiative since 2001. We administer the statewide tobacco treatment contract on behalf of the Maine Center for Disease Control and Prevention, and we work across the state of Maine to address tobacco use and exposure through education and policy and treatment and training initiatives. And we provide an array of training opportunities for providers and health professionals and others, including tobacco treatment specialist training, essential skills training, intensive skills training, our webinar series. And next week, we're happy to be presenting our Tobacco Treatment and Prevention Conference, our annual conference. Now, for those of you who are interested in pursuing the National Tobacco Treatment Specialist certification, we are a nationally accredited provider of the core training requirements through the Council of Tobacco Treatment Training Programs, or CTTP. And the completion of these core training requirements is necessary to pursue tobacco treatment specialist certification. And detailed information about that, about the tobacco treatment specialist certification, can be found on our website, which is ctimaine.org. And of course, today's presentation is part of that overall effort. As we gather in this place, we want to acknowledge that we are occupying the traditional territory and ancestral lands of the Wabanaki people, who for thousands of years have called this place home. We acknowledge their continued connection to this land, give thanks for allowing us to do this good work on their homeland, and remember their ancestors who were here before us. And lastly, references to tobacco in this presentation refer to commercial tobacco use and not the sacred and traditional tobacco used by indigenous communities. And one more, this is our standard disclosure side, just letting you know that we have no relevant financial relationships to disclose. Okay, so what we're going to do, we are going to, and not necessarily in this order, talk about some frequently asked questions that we get during our trainings that we do, our tobacco trainings, and go over that with you and give you some information about that. I want to talk a little bit about the biopsychosocial model of addiction, because cannabis and tobacco and all the other substance use disorders are one and the same. And we think about that, we talk about that using the biopsychosocial model. A little bit about concurrent treatment, some of the treatment approaches for co-users of tobacco and cannabis, a brief discussion about relapse prevention and recovery, and then some resources that for you and for your clients and patients as well. I just want to pose a little confidence questions for you first. This is a scaling question. And this is not something that I want you to weigh in on through the Q&A. Just want you to think about this. And at the end of the presentation, I want you to think about it again. See if we can move the needle a little bit on this. So this, like on a scale of 0 to 10, right, with 0 being no confidence at all, and 10 being the highest amount of confidence you can possibly have, how confident are you that you can effectively treat a co-user of tobacco and cannabis? So again, scale of 0 to 10, how confident are you that you can effectively treat a co-user of tobacco and cannabis? And just think about that. Just mull that over for a second. Give yourself a number. And I always talk about how we process scaling questions really quickly. So the first thing I do when I ask a scaling question to a client or a patient or a training participant is, why did you choose the number that you did? And why not a lower number? And it's always asking about the lower number. I never ask why you didn't choose a higher number. I always ask, why didn't you choose a lower number than the number that you did? Because I want people to talk about their strengths and their experiences and their skills and their knowledge and their abilities in the present time and focus on that. So why did you choose the number that you chose? Then the next question in processing a scaling question is, what has to happen for that number to go up by one? And usually I just say one. I don't want to challenge a person too much, right? So if they say a six, what has to happen for that to go to a seven, for example? So I want you to think about those two things, right? Where you put your number and what would have to happen for that number to go up by one. And then we'll revisit that at the end. If I don't think about it at the end, you can revisit that um, at your leisure. All right, so I want to talk a little bit first about the biopsychosocial model of addiction. So the biopsychosocial model of addiction acknowledges that addiction is a complex issue, right? It's influenced by biological and psychological and social factors rather than solely a biological disease or, as some people think, a personal weakness. So, what the model recognizes is that all three areas interact to impact an individual's risk for addiction as well as their recovery and their treatment. So the biopsychosocial model emphasizes the importance of addressing all three factors when treating addiction. And this means tailoring treatment plans to the individual's unique needs and taking into account their biological, psychological, and social contexts. So by considering all three of these areas, treatment can really be tailored to the individual's specific needs and circumstances. And I think very importantly, the biopsychosocial model helps to reduce stigma associated with addiction, as it acknowledges that it can be influenced by factors that are sometimes way beyond a person's individual control. So if you've ever taken another one of our trainings, another one of CTI's trainings, you've heard us say repeatedly that evidence-based treatment for tobacco use disorder is a combination of medications and counseling. So medications can help mitigate some of the physical aspects of the disease, but they can't do the whole job alone. That's where counseling comes in. So counseling or person-to-person interaction, as I like to call it, is necessary to address the psychological and the social parts of the disorder. So medications won't help people learn new skills or challenge their thinking patterns or make recovery plans. So a holistic approach can lead to better long-term outcomes as it addresses not only the addiction itself, but also the underlying factors that contribute to it. So both of the disorders we're talking about today, cannabis use disorder and tobacco use disorders, we can think of those as biopsychosocial diseases. So what is addiction actually? So the American Society of Addiction Medicine, or ASAM, they define addiction as a treatable chronic medical disease where people with addiction engage in behaviors or use substances that become compulsive and often continue despite harmful consequences. And that's the benchmark, really. They continue to use the substance despite negative consequences. And it's despite it causing difficulties in their lives, in their health, and in their daily lifestyle. But the definition also says that prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. And that's true for tobacco use disorder as well, or any other substance use disorder for that matter. So people addicted to substances, including tobacco and cannabis, don't have a bad habit, right? They don't lack willpower. They don't have moral shortcomings or flaws in their character. All of these things have been used to describe them, right? And these descriptions are simply wrong. What these individuals do have is a chronic, often relapsing addictive disease of the brain. So let's just do a brief dive into some brain chemistry. So when someone experiences some kind of rewarding stimuli, right, it leads to dopamine being produced in the reward center in the brain. And that's a very primitive part of the brain. And then dopamine is then sent to other parts of the brain. And these increased dopamine levels cause reinforcing and addictive behavior towards the rewarding stimulus, in this case, a psychoactive substance, right? So dopamine, we know, is a chemical that gives us pleasure, and it impacts motivation by marking the experience as essential for survival. So, what do we need to survive? We need to eat, we need to drink, we need to have sex, for example. Dopamine marks these experiences as pleasurable, and we want to repeat them over and over again. The problem is that psychoactive substances impact the system in the brain and cause very, very high levels of dopamine to be released. So, in effect, in a very deep part of the brain, people are getting the message, I must continue this behavior in order to survive. And then on the other hand, that prefrontal cortex is responsible for what we call executive functions, including higher level cognitive skills that are needed for things like self-control and managing behaviors. And these functions allow people to do things like follow directions and focus and control their emotions and also weigh the consequences of our decisions, right? We take those consequences of our decisions and actions into consideration. And so this prefrontal cortex often acts like a stoplight to behavior with negative consequences. And the reward center is more like a go light, the green light, right? To continue whatever behavior feels good. So what happens with addiction, what happens over time is that the prefrontal cortex gets weaker and the reward center of the brain gets stronger. And we call that hijacking, right? That's why you hear people say when we talk about addiction, addiction hijacks the brain. What it does is weaken the prefrontal cortex and it strengthens the reward center. So, and to further complicate that situation, after repeated exposure to substances, the brain cells can change. And the effect of this reduces the body's ability to actually release its own natural feel-good chemicals. So we start to rely on that substance. So what starts out as a like becomes a want and then a need, and it turns into an obsessive drive to keep seeking more and more of the psychoactive substance. And this is true for any drug, right? It's true for any drug. The mechanisms might vary slightly about how that drug acts in the brain, but the bottom line is they all end up with this dopamine release, and they all end up with this cycle and eventually the hijacking of the brain. So that's why we call this a brain disease. And substance use disorders, all substance use disorders, all right, they're all the same. There's no difference in these criteria: tobacco, cannabis, stimulants, opioids, alcohol, they're all the same. They're diagnosed using the Diagnostic and Statistical Manual of the American Psychiatric Association, and they all have exactly the same diagnostic criteria, and there are 11 of them, right? And the more criteria you have, the more severe the disorder is. For example, 2 to 3 criteria is a mild substance use disorder, 4 to 5 is a moderate substance use disorder, and then 6 or more is a severe substance use disorder. So the bottom line with this is that a really good, comprehensive, detailed assessment is crucial to determining the severity of a substance use disorder. And note, right, that the threshold is just 2 of the 11 symptoms. So, for example, 2 to 3 criteria is going to indicate a mild substance use disorder, but a substance use disorder nonetheless. So, we have to make sure that we consider that. So, I want to jump into some frequently asked questions. And you might find these really interesting. So, we understand, right, so far the biopsychosocial nature of substance use disorders and have a grasp on how addiction affects the brain, right? And we also know that all substance use disorders, regardless of the substance, all affect the brain in a similar manner. So keep this all in mind, right, for a bit later when we discuss treatment approaches for co-users of tobacco and cannabis. But for now, let's switch some gears, right? We're going to share some questions we always get about cannabis when we do our tobacco treatment trainings. Because if we get these questions, then you're going to get them too from your patients and your clients. And we want to be prepared to offer factual, data-driven answers for them so they can make the best decisions for themselves and their recovery. So let's hop into this. So here's the first one, right? Is smoking cannabis as dangerous as smoking cigarettes? And while both cannabis and cigarette smoke contain harmful substances, they differ in their composition, right, and effects on the body. So both contain toxins, both contain irritants and carcinogens, and both can damage the lungs and airways. On the other hand, we know that cigarette smoking is a major cause of various cancers, heart disease, and lung diseases, while cannabis smoking carries risks, particularly respiratory issues. Its long-term effects, they're still being studied. We still don't know everything, right? For example, studies indicate or suggest that cannabis smoke is not implicated in lung cancer, interestingly enough. And in fact, it may even minimize some of those carcinogenic pathways, which is really interesting. But other studies show that marijuana smoking may be more dangerous than tobacco smoking due to factors like inhalation patterns. Think about how you inhale marijuana smoke versus tobacco smoke and keep it in, right? And tar levels in cannabis smoke and potentially higher concentrations of toxins. So, how do we answer this question, right? So, I think it's safe to say that both cannabis smoking and tobacco smoking can be harmful, but in different ways. And here's a rule of thumb, right? Inhaling any kind of smoke is going to be dangerous. Is secondhand cannabis smoke as toxic as secondhand tobacco smoke? We always get this question as well. We know the health effects of secondhand tobacco smoke. It's well documented. Secondhand cannabis smoke contains many of the same harmful chemicals as secondhand tobacco smoke, including carcinogens and fine particulate matter. So exposure to secondhand cannabis smoke can lead to a range of health effects, including lung irritation and asthma attacks, and even an increased risk of respiratory infections. Also, secondhand cannabis smoke contains tetrahydrocannabinol, or THC, and that's the compound responsible for most of cannabis's psychoactive effects, or the high. So THC can be passed to infants and children through secondhand smoke. And people exposed to secondhand cannabis smoke can experience those psychoactive effects, such as feeling high. So, similar to our previous question, inhaling any kind of smoke is dangerous. And for those who are wondering, yes, third-hand cannabis smoke is a real phenomenon, right? And it poses potential health risks, especially for children. And research on this is still in its early stages, but it's believed to pose similar risks, right? Secondhand cannabis smoke is believed to pose similar risks as um, secondhand tobacco smoke, and even third hand, right? So you're familiar with third-hand tobacco smoke. Cannabis smoke can also create third-hand cannabis smoke, and that is believed to pose similar risks as third-hand tobacco smoke as well. Ah, is delta-9 THC, tetrahydrocannabinol, as addictive as nicotine? And the answer to this general consensus is no. All right, delta-9 THC is not as addictive as nicotine. Is it addictive? Yes. Is it as addictive as nicotine? No. So nicotine has an extremely high addiction potential. And what is that? What is addiction potential? Addiction potential refers to drugs' tendency to cause dependence and compulsive use, leading to a substance use disorder. And that's determined by factors like how quickly a drug produces a euphoric effect, its duration, and the development of tolerance and withdrawal symptoms. We know for sure nicotine creates strong physical dependence and intense cravings and intense withdrawal symptoms. And substances that have a similar addiction potential include heroin and cocaine and methamphetamine. So THC has a lower addiction potential, but can lead to cannabis use disorder, right, or CUD, especially with chronic and heavy use. And we think about, remember those 11 symptoms, right? We don't have to have 6 symptoms to have a severe substance use disorder. We can have a mild or a moderate substance use disorder as well. So, and withdrawal symptoms with cannabis from Delta 9 THC are also generally less severe as compared to nicotine withdrawal. Is CBD safer than THC, right? Another question we get a lot. So cannabidiol, CBD, right? And THC, tetrahydrocannabinol, they're both cannabinoids that are found in the cannabis plant, but they have distinct effects on the body. So THC is the primary psychoactive compound, and that's responsible for the high associated with cannabis. And while CBD is non-psychoactive, it doesn't produce that similar feeling. And CBD is often sought for its potential therapeutic benefits, right? While THC is more known for its high, for its psychoactive benefits, or sometimes therapeutic effects. So generally, CBD, in a sense, is considered safer than THC because it has a lack of psychoactive effects and also because it has fewer reported side effects. And while both substances can have potential benefits, right, THC is associated with a higher risk of adverse mental health effects and addiction, especially in adolescence. Okay, is tobacco smoking a gateway to cannabis smoking? And yes, right, tobacco smoking is often considered a gateway to cannabis use, meaning, right, it can increase the likelihood of someone using cannabis later on. And a substantial amount of research supports the idea that cigarette smoking precedes cannabis use, especially in youth. However, some studies also report a reverse gateway effect where cannabis use can actually lead to an increased likelihood of tobacco use. So it can go both ways, right? So we call both of these substances gateways, right? It can go one way or it can go the other. So it has that reverse um, gateway effect. And then our last one, are there any medications available to treat cannabis use disorder? And the answer is no, not currently. All right. There are currently no FDA approved medications for the treatment of cannabis use disorder. And that being said, there have been a number of clinical trials investigating different medications, but so far, like nothing definitive has been found. There's been a few, kind of bright spots and some promising results, but really nothing so far. Um, but research also suggests that treatment for tobacco, right? So using the FDA approved tobacco treatment medications, which we're going to talk about in a few minutes, that may decrease the use of other abuse substances as well, not just for cannabis, but for other substances that somebody might be being treated for, and can also enhance treatment outcomes. So if someone's in treatment for cannabis use disorder, um, and they're also a tobacco user, and we're treating their tobacco with tobacco treatment medications, that can also have a positive effect on their cannabis use, which we think is very, very interesting. So those medications seem to help for other substance use disorders as well. All right, I want to jump to some mechanisms that link these two substances together. So mechanisms that link tobacco and cannabis together. So tobacco users who are also cannabis users are more likely to be daily smokers of tobacco. And more likely to develop tobacco use disorders than non-cannabis users. And also, tobacco smokers who experiment with cannabis are more likely to progress to cannabis use disorder than non-smokers. And using some data from the National Household Survey on Drug Use and Health, it's estimated that the probability to develop cannabis use disorder was more than 8 times greater in tobacco users than in non-tobacco users. And the reverse, that the probability to develop tobacco use disorders in primarily cannabis users was more than 3 times greater than non-users. So in other words, if you're a tobacco user, you have an 8 times greater risk of developing cannabis dependence. And if you're a cannabis user, you have a 3 times greater risk of developing tobacco dependence. So, question for you. Um, what percentage of adult cannabis users report that they use tobacco? And this one with you use the Q&A to see what you think about this one, right? What percentage of adult cannabis users report that they use tobacco? Let me pause for just 30 seconds or so and see what you come up with. I can't see that chat, or Alicia, so maybe you can let me know what people are.
I am taking a look, and it looks like we've got 3 reporting 52%. We've
Okay,
got 1 at 26%,
okay.
2 at 78%,
Mm-hmm.
maybe 3 at 78%, and
Okay.
then 2 more at 26, another C at 52.
So nobody wrote in and say 0, right? No, there's no,
Not
like,
a
no,
not a single
okay,
one.
not yet. Okay. Well, the answer is 78%. And what we've seen in recent years is this comorbid use patterns, an increase in the comorbid use patterns of cannabis and tobacco. And that's been observed both in adults and adolescents. So these recent studies, the most recent studies, show that about 78.3% of past month adult cannabis users reported past month tobacco use as well. And that trend is being observed among both males and females of different age ranges and most racial and ethnic groups. So what we can say is there's a high correlation between these two things. Safe to say. All right, let's take a look at a couple of linkages. All right, what links these two substances together? So the first is shared genetic risks. So research shows that genes are responsible for about half the risk for addictions. So, and while genetics are not the sole determinant, all right, their presence or absence may increase the likelihood that a person is going to become dependent on a substance, whether it's alcohol or other drugs, including nicotine, including cannabis. So it is possible to hypothesize that there are common or correlated genetic factors that increase the risk for both tobacco use disorder and other substance use disorders as well. So there have been some genetic studies um, studying something called the addiction vulnerability hypothesis. And what those studies have shown is that there are common genes related to tobacco initiation as well as other substance related problems, suggesting that maybe there are some specific neurological pathways that make some individuals predisposed to addiction. And individual differences in tobacco and other substance use, they're partly attributable to genetic factors as well. So studies have shown that the same genetic factors responsible for substance use have also played a role in the development of things like impulsivity and conduct disorder, um, as well as sort of a general propensity to all drug use and drug misuse, and also things like sensation thinking, seeking, and general problem behavior. And I want to kind of circle back, um, talking about the biopsychosocial model, because that biological part, again, this is something that's beyond an individual's control, right? They are not, in control of what genes they have. They're just dealt this deck, right? So we have to, stop thinking about this as a personal, character flaw or moral shortcoming or weakness or, personal choice or self-inflicted wound or those types of things, because just the very biology of a person can determine their vulnerability to a substance use disorder, regardless of what the substance is. And then we have the environmental and behavioral and social cues associated with using these drugs. And so there are aspects of the environment, and this includes peers, right? And the availability of the substance, particularly now, right, with um, the basic legalization of cannabis, exposure. I'm amazed at the amount of dispensaries that I see, popping up all over the place, um, and access, to these substances. And that just encourages use. It encourages, and these substances are so closely linked together, it encourages the use of both tobacco and cannabis. And consider the social milieu of smoking, right? So cannabis smoking and tobacco smoking, they share a lot of very, very common characteristics, not the least of which is the route of administration. So an interesting fact, um, about tobacco and cannabis co-use is that the route of administration is both predominantly inhalation by smoking. So the adaptations one makes by smoking one drug facilitates the use of the other. Now, for example, a tobacco user who experiments with cannabis, right, may continue to use past experimentation simply because the experience of inhaling smoke is more pleasant for them than for a non-tobacco user. And tobacco users may also experience more positive subjective reactions to cannabis and therefore continue to use it. Just the act of smoking is pleasurable. And we know well what some of these effects are, right? Alteration of consciousness. This is with cannabis, particularly euphoria and feelings of well-being, um, all kinds of different things, relaxation, stress reduction, um, enhanced recollection. Sometimes we hear increased sensuality. Sometimes we hear creativity. We hear all of these things. These subjective effects of cannabis may be enhanced um, if someone's also a tobacco user, and co-administration or use of both substances at the same time may have an additive effect as well, um, which means that greater pleasure is experienced. So using both of the things together actually enhances the effects of both of these drugs. And we don't really know exactly what the interaction is, how that happens. But what we do know, there is some evidence that each drug may reduce some of the unpleasant effects of the other. And this is called negative reinforcement. So one drug kind of reduces the negative effects of the other drug and has the effect of enhancing the experience altogether. So the route of administration is extremely important when we talk about these two drugs. And then we talked about this a little bit before, the gateway drug. So a gateway drug is the first in a sequence used, right? So that means it's used prior to other drugs. So in addition, a gateway drug is associated with an increased likelihood of using another drug. So they just don't start with one drug and then stay there. There's an increased likelihood. If it is a true gateway drug, an increased likelihood they're going to use another drug in the future. So we saw this in the section on frequently asked questions, right? A common discussion is whether tobacco was a gateway for other illicit psychoactive substances. So the sequence of that drug use depends, right, on the ease of access and other factors. And adolescents commonly may use tobacco prior to cannabis due to its availability. So, but we've also seen that there's evidence that lends support to this concept of the reverse gateway, right, in which cannabis is used prior and increases the risk for tobacco use. So, in effect, both cannabis and tobacco can be considered gateway drugs. So, I want to pause there and see if we have any comments or questions or observations or reactions so far to what we've talked about.
Hello, Edward. A couple of questions that have come in. Can you explain third-hand smoke?
Yes. Secondhand smoke is the smoke that is in the air, right? So when someone smokes a cigarette or a cannabis joint, smoke gets in the air, you can see it, right? And you can breathe it in and all that kind of stuff. Third-hand smoke is what happens after that secondhand smoke settles, because those are particles, right? Secondhand smoke is made of particles, whether it's cannabis or whether it's tobacco. And those particles will settle out of the air and they'll settle on everything. They'll settle on walls, they'll settle on furniture, they'll settle on carpets. Maybe the best way to explain third-hand smoke is if you've ever had the experience of getting into somebody's car who's a heavy smoker or even a moderate smoker, you can smell that smoke. You can smell the evidence that that person is a tobacco user, and there's no smoke in the air. But what it is, it's coating everything, right? And you can smell that. So that's third-hand smoke is what's left after the second-hand smoke actually settles out, right? And it doesn't just stay on the surface. It can be like disturbed, right? If a child runs across it or a dog runs across it or you walk across a carpet, that stuff can actually be put back into the air that then we can actually inhale it. And children crawl around on the carpet, they put their hands in their mouth, they, gets on toys and clothes and things like that. So, and though that third-hand smoke is toxic material, right? So we're getting those chemicals into our system um, just from touching it, right? And just from having it on our clothes and having it on our furniture, having it in our car, for example. So that's the
Thank
third
you,
hand smoke. That's a
Edward.
pretty recent, not as recent, in the past, several years, we've started to talk more about third hand smoke and the dangers of third hand smoke.
Just a follow-up question to that, Edward. Will third-hand smoke still impact us if we move to an apartment, for example, that used to belong to a smoker?
Absolutely, right? It almost almost never goes away, right? Depending on the frequency and amount that the person smokes. You walk into a place, excuse me, and you know if the person has, that lived there has been a smoker. So yes, that stays, and it's almost impossible to clean it. It's almost impossible to get rid of it. In really serious cases, the house just has to be gutted and all new stuff has to be put in, even right the walls, because this smoke actually permeates the sheetrock on the walls and stays there. So the walls have to be all gutted and the carpets have to remove and the drapes and everything just taken out and all new stuff put in. So definitely yes, and I bet you a lot of you have had that experience as well.
Thank you, Edward.
Sure.
Can you always see secondhand smoke?
Yeah, normally, cigarette smoke is pretty easy to see. Cannabis smoke exhale is pretty easy to see. Vapor even from
Mm-hmm.
electronic devices, depending on how how sly the person is in using their vaping device, usually can be seen. In fact, some people have contests about how big a cloud of vapor they can exhale into the air. Less known about secondhand vaping aerosol. We don't know a lot about that yet, although I wouldn't want to breathe it. Just myself, I would not want to be in a room where a lot of people are vaping and I'm inhaling that secondhand vapor as well.
Great. Thank you, Edward. And then one more that we have time for, I think, does cannabis act as a stimulant on the brain? Do stimulants tend to release more dopamine in the brain compared to other substances like alcohol?
Interesting. Stimulant, cannabis, THC is actually a form of a hallucinogen. It more acts more like a hallucinogen in the brain than it does a stimulant. So if you wanted to categorize it, I would put it in that category of hallucinogenic substance. Um, and I can't definitively tell you which drug releases more nicotine or more dopamine. What I can tell you is those drugs with the higher addiction potential tend to release more dopamine into the brain because that creates that that intense high and that drive to continue using that drug. So they all do the same thing, maybe at different levels, right? And in different intensities. But the end result basically is the same. Okay, let's move on from there. And I'll pause again in a little bit to take some more questions. But it is interesting to note, right? This is really interesting that cannabis use alone, right? There's little evidence that cannabis use alone poses an increased risk for lung cancer. And I thought that was really interesting, right? Among habitual, even long-term users of cannabis. And there was a very large study led by the University of California at San Francisco and the University of Alabama. They collected data from more than 5,000 adults for more than 20 years. And the conclusion was that moderate use of marijuana is less harmful to users' lungs than exposure to tobacco. While other research, right, has suggested that while they're chemically very similar, there are fundamental differences in the pharmacological properties between cannabis and tobacco smoke. So, in very simplified terms, components of cannabis smoke can actually minimize carcinogenic pathways, which is kind of interesting, while tobacco smoke enhances them. And then another finding showed that nicotine promotes tumor, they call it angiogenesis or blood vessel growth, whereas cannabis use inhibits it. So it's really interesting to look at those two things. So current knowledge does not suggest that cannabis smoke will have a carcinogenic potential comparable to that of tobacco smoke. So cancer risk could be less. But that being said, other research shows that in both inhaled cannabis smoke and secondhand cannabis smoke, we see many of the same chemicals, right, as found in tobacco smoke. And that includes carcinogens and other chemicals implicated in particularly respiratory diseases. So we know definitively that smoking cigarettes can cause significant lung damage. And we know that smoking causes lung cancer. We've known that since 1964 in the Surgeon General's report. We know that almost 500,000 Americans die annually of tobacco-related disease. And as we've seen, almost 80% of cannabis users are also tobacco users. So it's really hard to tease out the data strictly for cannabis. But the bottom line is comorbid use of cannabis and tobacco. This is a serious public health issue. And we do know that co-users of cannabis and tobacco experience greater respiratory symptoms than exclusive tobacco smokers. And one recent study found that even though co-users reported smoking the same number of cigarettes as exclusive tobacco users, they had a considerable elevation in respiratory distress indicators and reduced lung functioning. So co-use has been linked to that. And cannabis smoking has also been linked to chronic bronchitis And a cannabis um, joint can produce as much airflow obstruction, this was an interesting study, as 2.5 to 6 cigarettes. So one joint can produce as much airflow obstruction as 2.5 to 6 tobacco cigarettes. And there are some known additive risks for toxicant exposure as a result of co-use. For example, increased exposure to carbon monoxide, because when you burn anything, there's an increased risk of carbon monoxide inhalation. So in the behavioral area, right, individuals with comorbid use, they're more likely to report antisocial behaviors, and they're more likely to meet the criteria for psychiatric disorders, including things like um, anxiety disorders and bipolar disorders and even personality disorders. And co-users were more likely to drop out of school earlier or drive under the influence of alcohol, which is interesting, or even be involved in partner violence. And in addition, there is an increased incidence in depression among co-users, especially males. And in a study examining the relationship between cannabis and cigarette use and psychotic experiences, it was observed that co-use, so co-use of cannabis and tobacco, was associated with a 3 to 4-fold increase in psychotic experiences. So, co-use of these two substances, we talked about maybe the benefits that some people see before. Now on the negative side, right? We see that what co-use can do in terms of using these two substances. All right. So given all that, right, what are some treatment approaches for co-users, right? How can we approach this? Because this is a difficult one. So first of all, we want to treat tobacco use disorder and other substance use disorders, including cannabis use disorder, concurrently. So we call addiction a primary, progressive, chronic, and fatal disease. That's how I describe it. Primary, progressive, chronic, and fatal. It doesn't matter what the substance is or whether the course of the disease differs for different substances. The bottom line is that we're not providing the best possible care if we ignore one addiction while trying to treat another. The linkages, right, are just too strong. We can't do it, right? Research is clear. Treating addictions concurrently results in better treatment outcomes and stronger long-term recovery. And it's really interesting. I was listening to a show on NPR as I was driving in today, and it was talking about a whole different arena of treatment and providing treatment. It was for a specific set of illnesses, but the presenter used the term which I really thought was interesting. She used the term of dereliction of duty. It was a dereliction of duty if we didn't provide treatment for this particular disorder. And I thought to myself, that's a good description of if we don't treat all substance use disorders concurrently, treat them at the same time because they're all the same, as we've seen in our studies of the brain and in our biopsychosocial discussion, it's a dereliction of duty. I kind of really like that. I want to use that term because it's really interesting. It kind of points to the fact that it's up to us, right, to provide this care in a comprehensive way. So what are the benefits, right? This is from a study that reinforces the concept of concurrent substance use disorder and tobacco use disorder treatment. So people are serious about their recovery, right? You see it every day. Our job is to make sure we're providing the best possible treatment for our clients and our patients. And they look to us for guidance and direction. And the evidence now tells us definitively, right, that quitting tobacco, along with a person's drug of choice, I put that in quotation marks, right, drug of choice, actually makes recovery stronger. And it's not a relapse dynamic like we used to think. I used to think that, for the first 25 years of my career as an addictions therapist, I would tell people not to stop smoking. It's a relapse dynamic, and I was totally wrong. In fact, the opposite is true, right? Smoking makes relapse more likely, right? So, using that term again that I learned today, it's a dereliction of duty not to treat both of those substances at the same time. And they also, that drug of choice, that's kind of an older term in the addictions field. What is a person's drug of choice? Well, their main drug that they use, it might be heroin, or it might be alcohol, or it might be crack, or whatever it is. And I used to, later on, when I understood that concurrent treatment is people a little bit, my drug of choice is alcohol, but I'm still drinking or still smoking. My drug of choice was heroin, but I'm still smoking. And I would challenge them is what really is your drug of choice then? Is it nicotine, or is it alcohol, or is it opioids? What is it? So it challenged people that way, right? So it doesn't matter. A drug is a drug is a drug, right? So providing tobacco use disorder treatment concurrently with treatment for other drugs improves outcomes. And one of the best things you can do for your recovery, if you want to say this to your patients and your clients who are in recovery from other substances, one of the best things you can do for your recovery is to quit smoking. Let me know when you're ready. I can help. Right? If you take nothing else away from this presentation today, remember that sentence and repeat it to your clients and your patients. One of the best things you can do for your recovery is to quit smoking. Let me know when you're ready. I can help you. All right, let's do some treatment approaches. So concurrent treatment is best practice. All right, we just established that. But what does that treatment look like? So first of all, just a note here that multiple forms of counseling, and again, person-to-person interaction, right, are effective because we have to address the psychological and social parts of that biopsychosocial illness. On the slide, we see individual and group and telephone counseling, and of course, more recently, a variety of online and virtual resources, telehealth, are also effective. So no matter how you do it, we really need to increase this person-to-person interaction. So take every opportunity you have to have these conversations with your clients and your patients, and your approach really matters. So we're not wrestling with people. We're trying to convince them, we're helping them to create a space in which they can consider making a change. So there are very effective substance use disorder treatment interventions, and then there are ineffective ones as well. If you do an effective intervention, the patient's going to feel supported. They're going to feel understood. They're not going to be judged, right? They're also going to have the freedom to think about whether they want to stop or not, and that maybe take one step closer to that ultimate goal. And you do that by having a level of compassion and empathy, legitimizing their struggle. You see that on the slide. That means we understand this person has an addiction, a brain disease, and there's a lot of factors that are out of their control, right? It's not a character flaw. It's not a lack of willpower. There's a lot of shame and guilt and hopelessness that exists. We know that. They know that it's bad also. We don't need to hit them over the head with that all the time. And one of my favorite things as a therapist is to ask permission to give information. Ask permission to give information. It respects the client. It makes them feel part of that conversation. It creates a therapeutic alliance, right? A relationship, a collaboration, a partnership in dealing with this particular illness, this particular disease. And be compassionate. I know everybody listening to this right now has got to be a compassionate person. Otherwise, you wouldn't be here listening to this. Compassion and genuineness and empathy, regardless of what the drug is, right? So we talk a lot about people being wanting to change, but not ready to change. But what does it really mean to be ready? What do people need in order to be ready to make a significant change in their life? And first, they need to feel that it's important enough. We know, at least with tobacco, we know that 70% of users express a desire to quit. So it seems like importance is pretty clearly established with that. And if a substance is having a negative impact on your life, um, I think it's safe to say that a lot of people would rather not have that happening to them. They'd rather be substance-free. So importance is, in terms of readiness to change, that's an important component. Second, they need to have the confidence in themselves that they can be successful in changing. And whether you call it confidence or self-efficacy or resilience, it's a necessary component of readiness. So the majority of our work with clients is actually helping them to build up their confidence so that they can change. And the techniques of MI or motivational interviewing are designed to do exactly that, whether it's tobacco or cannabis or both. So for those people who are considering changing, an MI approach is going to be really helpful. What you don't want to do are these two things, right? So if I'm sure that you know that when you're with a client, everything you say or do has an impact. When we say things to a client, they're going to have a reaction to what we say. I like to characterize this as the way something lands with a client. How does it make them feel? So we have to be wary of falling into traps. And there's one of them is called the writing reflex. And I can almost guarantee that at some point in your lives, someone, perhaps a parent or maybe a spouse or a partner or a friend, they pulled the writing reflex on you, right? And in your heart of hearts, you knew that they were right. You should do exactly what they were saying, but you didn't. And the reason you didn't was because they told you that you had to. So people react negatively to the writing reflex. They react negatively to being told that they're doing something wrong and they need to do something different, right? It's not a motivational approach. Even with the best of intentions, it can backfire. And the other is the expert trap. And the expert is someone who tells people what to do and how things should proceed, and sometimes what to think and what to say, because the expert knows all. And this is not a client-centered approach. The expert is basically saying, you don't have to think. I'm going to do your thinking for you. And unfortunately, the message might be that the client is hearing is, I don't have the capacity to change. I don't have the capacity to solve this by myself. And they become dependent on the other person to solve all their problems for them. So the expert style doesn't do anything to tap into that client's own problem solving strategy. So these are the things that you don't want to do. All right, so we developed this graph at CTI to illustrate how a client's readiness to change can drive your decisions on the best kinds of interventions and techniques to employ with somebody and which type of treatment group might best serve their needs. So it's likely that a large number of clients that we're working with are in the contemplation stage of change, and they're thinking about making a change, but they're not yet ready to put the thinking into action, right? So they're in that not quite ready, that red dotted line, right? They're in that contemplation stage of change. And as you can see in the graph, the motivational interviewing approach is going to best meet their needs. So the techniques of MI are designed to help people articulate, resolve their ambivalence, for example, move in the direction of positive change. And you never know, right, when that client, when that person, when that patient is going to be ready to take action. I like to call it flipping the switch. So, but when that does happen, right, their needs are going to change, and then our approach is going to change. We're not going to use more of a cognitive behavioral approach with clients where we're helping them to discard some of those negative thinking patterns and embrace the power of positive thinking and learning to learn new skills and enable a lifelong recovery of substances. So that preparation stage of change, you can see in the graph, it's all about planning, right? It's no longer do I want to change? It's how do I change? So we're basically helping that client learn not only how to quit, but how to sustain that abstinence over the long term. So basically, a really good assessment of where a person is in terms of are they ready to change or are they not quite ready to change kind of determines our approach with them, right? So an MI approach is useful in the earlier stages of change, and the cognitive behavioral approach is useful in the later stages of change. So just very quick, a few things about MI. What is MI, right? And I'm sure most of you are familiar with motivational interviewing. A couple of quotes from the founders of motivational interviewing. This is from Stephen Rolnick. And Stephen Rolnick says, what is motivational interviewing? The ability to trust the wisdom of someone to know what is best for them and to structure a supportive and purposeful activity. In the case of motivational interviewing, a conversation so they work it out for themselves. Right. And here's what Miller says about it. William Miller, he says, people are the undisputed experts on themselves. I really kind of like that. That was my addition, right? I'm sorry. No one has been with them longer or knows them better than they do themselves. And MI, the helper, is a companion who typically does less than half of the talking. All right, from the horse's mouth, right? If you don't have this, if you're working with people with any substance use disorder, this is probably a really good read for you to have. And I'm sure you probably already have it, or one of your colleagues have it, or it's in your facility or your office building someplace. It's there. So it's a good read if you're interested in it. So in their book on motivational interviewing, um, they talk about what is MI. So it's a collaboration between two people, right? It's you and the client. I call it the therapeutic relationship. It's being non-judgmental. It's believing in the client that they have the ability to make that change, that they have the resources, right? And the problem-solving skills, not like the expert who tries to do everything for them. It's also a guiding style. It's not preaching or lecturing, but it's guiding them. So it's not trying to push them or pull them in any direction. It's basically helping them to find that solution on their own. And then you probably have some familiarity with motivational interviewing, have various levels of skill development. I did want to spend just a minute on the skills of motivational interviewing. So open questions, for example, reflective listening, summarization. These are known as the OARS skills. That's the acronym. Are the basic core skills that are used in the motivational interviewing approach. And these are person-centered, they are client-centered, and they help clients to explore and resolve their ambivalence. So using these core skills to evoke the arguments for and against change, create that safe place, and allows the client to really weigh the pros and cons of changing. So do as much motivational interviewing training as you possibly can. Take every opportunity to do some work with MI because MI is the best way, the evidence-based way to help people in this change process, to help them get ready to make a change. Really, really has positive effects. All right, tips for giving information. So it's important to keep certain things in mind about our patients. They may be coping with enormous shame, right, and guilt about their use. And they may have dealt with providers in the past who've lectured them, for example, and scolded them, assuming that threats are going to induce them to quit. So they may have acted like the expert that the patient needed to listen to, not a caring collaborator like you want to be, right, causing the patient to feel unheard. So we have to be sensitive to that, right? And patients may have tried to quit many times before, to the point that they feel hopeless. So it's important to tap into your empathy and your compassion. Your clients or your patients, they're going to feel that. They're going to know it if you're empathetic and you're compassionate. Let them know that you know that their struggle is real. You get it, right? And this creates that safe space to allow them to share with you. It's always possible also, you're going to be asked about your own history of substance use and what should you do? You should be honest. Um, the way I usually deal with that is, when people ask, well, you were never, had a substance use disorder, you were never a smoker, how are you going to deal, how are you going to help me? And I usually frame it as, well, you're the expert on you, and I have some expertise in other areas. If we put those two things together, right, then we're going to create a positive outcome with those. We're going to use your expertise and my expertise. I love this idea of having two experts in the room, and two experts in the room are going to help us get to that goal that you want and I want, right? And we're going to do this together. We're going to walk together this journey and we're going to get to that goal, right? So generally, we try to minimize self-disclosure, but if you're going to do it, right, be prepared because you are going to get that question from your clients and your patients. And then this is so important, right? Imagine seeing a fundraising thermometer on the side of the street, and each day you drive by, you see more money's been donated, right? And it's getting closer and closer to the goal. This is how we see our patients. This is how we see our clients. Each time they're seen by a healthcare professional, you ask them about their substance use and you offer them help, right? And every one of those interventions is one of those little notches, right, in that thermometer. Um, think about this as substance use disorder interventions, right? Each one we do is getting them closer and closer to that goal, right? So the process is really important. That's why every time we meet with them, every time we see them, every time we have an opportunity, that we want to talk to them about this. We want to have a conversation with this. We want to use that motivational approach and open questions and reflections and affirmations as much as we can. That's what helps people get ready. Okay, and what about those people that are ready, right? So how do we help those who are ready to change? So CBT, or cognitive behavioral therapy, um, this is a very popular, again, evidence-based method. It's been used for a range of problems, including substance use disorders, and it assumes two key principles, right? First is many problems are based in part on faulty or unhelpful ways of thinking, right? So CBT involves efforts to change distorted thinking patterns. And then second, problems are also based on learned patterns of unhelpful behavior. So CBT, in addition, involves efforts to change behavioral patterns that tend to exacerbate the problem. So, in effect, cognitive behavioral therapy. So CBT is an evidence-based treatment. It's been shown to be very effective in treating substance use disorders. But before I go any further, I want to make a point. Switching to a cognitive behavioral approach doesn't mean, by any means, abandoning our motivational techniques. So the techniques of MI are still important and necessary as a client's motivation can ebb and flow, right? It can fluctuate, and we need to be ready to employ those motivational interventions that can help a client get back on track. So even though when a client is ready to make that change, CBT might be our primary approach, we're still keeping that MI toolbox handy. Okay, so that being said, basically there's two categories of interventions. In CBT, there's a cognitive intervention and there's the behavioral intervention. So cognitive interventions assume that processes can, to a significant extent, be controlled and changed by the individual. And this is exercising the mind to think differently, right? So behavioral interventions, on the other hand, are designed to affect the actions that people take with regard to their health. So these interventions encourage people to do something about it. So in the most basic terms, thinking leads to behavior. So negative, distorted thinking is going to lead to problematic, unhealthy behavior. And of course, the reverse is also true, right? Helpful, positive thoughts lead to increased motivation for healthy behavior. So again, people are learning how to remain substance free. Of course, they're going to need a little assistance in this, right? Figuring out how exactly to exist in a substance free state. So, in addition to restructuring some of that disordered thinking that they have and unlearn some of the unhealthy behavior, we're also going to help them learn new skills, right, to anchor those new behaviors. So, learning new coping skills, learning new stress reduction methods, and handling cues and triggers and dealing with high risk situations, expecting the unexpected, not only enhance positive thinking, but also equip that client with tools, right? Equip that client with tools and skills they need to fill up the toolbox to accomplish that task. So in a sense, right, we're just filling up their toolbox. We're giving them more skills that they need. Okay, so as I mentioned earlier, there are no current FDA-approved medications for the treatment of cannabis use disorder, and the use of Tobacco treatment medications, though, during concurrent treatment can improve both tobacco and cannabis use disorder outcomes. So keeping that in mind, I did want to briefly go over the medications for tobacco use disorder. And as you can see, the most effective treatment for tobacco use disorder is a combination of counseling and medications. So let's quickly review the treatment medications. So we know that medications for tobacco use disorder are effective across a broad range of populations. There are 7 medications that reliably increase long-term abstinence rates. We definitely want to consider the use of combination medications. That's best practice now. Encourage every patient who is ready to quit to use medications. There's a few contraindications and use exclusions and considerations, but in general, all right, and this is not a comprehensive discussion of tobacco-free medications, but in general, most people who are um, want to quit using tobacco can use these medications safely with very few exceptions. And I encourage you to um, get more information on that. We have a lot of that available in our different trainings on our website and webinars, for example. They're safe. Medications are safe. They're effective. They decrease withdrawal symptoms. They can more than double the rates of becoming tobacco free. And remember, if someone is a co-user of cannabis, there is some evidence that they might help that disorder as well. There are 5 nicotine replacement therapies, also known as NRT. The 3 on the top, the nicotine patch, the nicotine gum, the nicotine lozenge, can be purchased over the counter without a prescription. The 2 on the bottom, the nicotine inhaler and the nicotine nasal spray, require a prescription. There's a great medication dosing guideline available on our website, ctimaine.org, and look at our resources section. There's a database there. You can get all this information. Medication dosing guideline is very, very, very helpful. There is a current lack of availability of the inhaler because of some manufacturing problems due to materials. But that, we certainly wanted to include that in our discussion here because hopefully it will become available back on the market. Again, 5 nicotine replacement therapies, also known as NRT. And the NRT guidelines have changed over time. And I think that's a good example of how a lot of outdated information is out there. So, for example, just a couple of these begin using NRT on their quit date. That was what we previously advised. Now we know that it's safe and acceptable practice to use frequent NRT. So you can actually start using NRT even before you stop smoking. It's perfectly safe. Um, Another bullet point, refrain from using NRT while smoking. And now we know, no, it's not necessary to do that. It's not necessary to discontinue using the nicotine patch or lozenge if you're still smoking, right? So again, the safety protocols, the safety guidelines have changed quite a bit with NRT, and we know it's very, very safe and very, very effective medication. And again, may help with other substance use disorders as well. Excuse me. And what is current best practice? Combination medications is current best practice. Much more effective than using a single product. So combining the patch and the lozenge, for example, is especially helpful. That's combining a long-term NRT. The patch is the only long-term NRT. The other 4 are all fast-acting or short-acting products. So combining those two can be very helpful, especially if the person is a heavy tobacco user, has a high level of dependence. And this is kind of new. This is still a new idea to some clients and providers, but it really can make a significant difference in the quit process and in success rates. And you can also combine NRT with the non-nicotine medications as well. And pre-quit NRT, which I mentioned, is a fairly recent development. So you can actually start using NRT even before you stop smoking. And this is a very attractive idea to a lot of people because you don't have to do that, very terrifying quit date and set that date where I'm going to not smoke anymore after that date. So we've actually changed it. Now we're calling it a start date. So instead of calling it a quit date, we're calling it a start date. Even if they're not totally abstinent from smoking, they're starting something positive. They're starting using that NRT and starting on that life of recovery. And then these are our non-nicotine medications. So there are two non-nicotine medications, both require prescription. So we currently have seven, right? We have five nicotine replacement therapies and two non-nicotine medications. Bupropion, you might be more familiar with this as Wellbutrin, same medication. It's an antidepressant. It's been found to reduce people's desire to smoke. And varenicline is the newer one, but it's been around now for quite a number of years. Goes by the brand name Chantix, and its only purpose is for tobacco treatment. Just want to mention a little bit about varenicline. It is what we call a partial nicotine receptor agonist. It reduces nicotine withdrawal and cravings. And people begin using this again before they stop smoking. Nausea is the most common side effect, so it's essential to take this medication with food and a glass of water. Um, and other side effects can include headache and insomnia and vivid dreams. But the safety protocol for this has also changed quite a bit. So now we know this is a very safe and effective medication. We used to be concerned about adverse neuropsychiatric events, but that's kind of been proven not to be the case. And bupropion, also called Zyban or Wellbutrin, as I said, it's also a non-nicotine prescription medication. It is a reuptake inhibitor. That's how it acts in the brain. It improves mood by restoring the balance of neurotransmitters. And people also start taking this medication a week before their quit date. It takes 5 to 7 days to reach therapeutic levels. So one interesting thing about bupropion, it's been shown to reduce weight gain, which is really interesting and attractive to a lot of people. And you can use NRT in combination with bupropion and with varenicline, actually, for that as well. So just kind of a really broad brush about the tobacco treatment medications. So what opportunities do you have to talk to your patients and your clients about substance use? Again, this is just a reflection for you to think about. You don't have to weigh in on this one, but just think about that. And the bottom line is take every opportunity that you have to have that conversation with them. Whether it's about tobacco use, whether it's about cannabis use, whether it's about other substance use disorders that they might be dealing with. And treatment intervention types. So what kind of treatment can you actually provide for people? Well, and this goes from less intensive to more intensive as our bullet points go. So it depends on your setting, it depends on your staffing, depends on your time, it depends on your expertise. So at the very least, you want to have materials for people, brochures and handouts and worksheets and so forth that you can give to people. Even a minimal intervention, even one question or one or two questions lasting less than 3 minutes is going to be good, right? It's going to be effective. It's going to put a little notch in that thermometer that we talked about. Of course, the longer you are able to talk with somebody, the longer you're able to provide counseling, provide person-to-person interaction, the better it is. And so we can have brief counseling, 3 to 10 minutes, or we can have more intensive counseling, which are generally considered to be greater than 10 minutes and meeting multiple times. So there is a dose response relationship. So the more interventions that you do and the greater the intensity of the interventions, the better the outcome is going to be. And then when I hear someone say, I don't want to stop, I think what they're really saying is, I'm not ready to stop, or I'm scared to try, or I feel bad enough already. I don't want to talk about it, or I've tried before and I couldn't do it. So let them know that you'll be there for them when they're ready and be a partner with them. One good strategy is to ask them what they might consider, right? For example, people might be willing to consider small steps, right? Rather than this overwhelming thought of stopping completely. And that's a harm reduction approach in a sense. And believe in them. Use language that presupposes change. For example, when you quit instead of if you quit. And even if a person says, I don't want to quit, right, or I'm not ready to quit, keep asking them at every visit about their substance use. They expect it. And remember, every ask increases the likelihood of their ultimate abstinence. So, a couple of brief comments about relapse prevention and recovery. And it brings us to this definition. So, relapse prevention is basically a cognitive behavioral approach for reducing the likelihood and severity of slipping or relapsing after stopping using substances, right? So, in other words, once you stop, right, how do you stay stopped? So, let's shift the language, right? So, again, we don't say tobacco cessation, right? We don't say cannabis cessation. We don't say alcohol cessation. Instead, we say recovery. So we say tobacco recovery, or we say cannabis use disorder recovery, like we do with any other substance use recovery. And I like this saying on the slide. It says, you don't recover from an addiction by simply stopping. You recover by creating a new life where it's easier not to use. And then the short answer is, how do you stay stopped? You enter recovery, a lifelong process. Recovery is that process of change that individuals go through to improve their health and wellness, live a self-directed life, and strive to reach their full potential. And you might have heard people say that they are recovering from an addiction to drugs or alcohol, including nicotine, but you don't often hear them say that they are recovered, right? In quotation marks. And this is an important distinction. It means that the process is dynamic and ongoing and can be a lifelong challenge for them. So this is a chronic disease, right? It doesn't go away. You can actually put it into remission, right? And people can live, you know, people can live high quality lives while they're recovering, but it's important to work at that. So recovery is a lifelong process. It's a work in process for anybody with a substance use disorder. So again, recovery is a process. So we don't want to talk about cessation. We want to talk about treatment. So a couple of resources. I'm going to shift gears and wrap up in the last 3 minutes by talking about some resources that are available for you and for your clients and patients. And the first is the Maine Quit link. By the way, we're having a whole webinar tomorrow on the Maine Quit link. So what I don't what I don't get to today, if you're able to tune in tomorrow for a webinar on the Quit link, it's a terrific program, and you're going to learn a lot if you're able to tune in. Um, but as the slide says, it's free, it's confidential, and it really does work. If you don't live in Maine, be sure to check out your state's Quit link, and there's a Quit link in nearly every U.S. state, so you can see the different services that participants can access: phone coaching, online medication support, website, some tailored programs, American Indian program, and My Life, My Quit, which is our tailored program for young people, for teenagers. Here it is, the tailored youth program, My Life, My Quit, 13 to 17-year-olds, and our program for our American Indian tailored program, American Indian commercial tobacco program. Um, Native American coaches, dedicated Native coaches, provides a customized quit plan and NRT medications. And then finally, a couple of slides about learning opportunities and resources that are available for you and your clients in terms of professional development. So this is our website, ctimaine.org. Sign up for our e-newsletter for updates about our upcoming trainings. And if you go onto our website, you're going to see all of our training opportunities, and most are eligible for CMEs and CEUs and CHES credits as well. And our materials database, I mentioned this is where you can get the medication dosing guideline. Very comprehensive here, a lot of provider tools, a lot of fact sheets, rack cards. I would strongly encourage you to check that out. And also the Maine Prevention Store. You can get a lot of those self-help materials that I had mentioned earlier. And a couple of more websites and resources for you. And you'll get a copy of these slides too. So you'll have this all at your fingertips. All right. And that brings us right to 1:30. Um, as always, we're always happy to hear from you with any questions or comments or suggestions. Here's our email. And just one closing thought for you, right? We're all individuals. We're all unique. We're all different in our attitudes and values and beliefs, but there's one way that we're all alike, the desire to help others find their way to health, vitality, serenity, and recovery. So thank you for being here today. Thank you for all the good work that you do. You make a difference, and enjoy the rest of your day. Peace.
Thank you so
Alicia.
much. Thank you so much, Edward. There are some questions in the chat, but I will download all of those. Edward will respond and we'll be back in touch. But thank you so much. It was a wonderful, informative webinar with lots of interaction and questions. So once again, this webinar was recorded. It will be posted to our website. And in order to claim CMEs, you must have a profile in Cloud CME. Instructions will be found in the post-webinar email. And for those that are collecting CHES credit, it will be sent to NCHEC after the event. You will also receive this information, a copy of Edward's slide deck, and the handouts in a post-webinar email. And then additionally, an evaluation will appear on your screen once the webinar is closed, and we ask that you take just a few minutes of your time to provide feedback. And any other follow-up questions, certainly at any time, please feel free to contact us at our tobacco training at mainehealth.org email. But thank you so much. Have a great day.
Thank you.